Welcome tonight to some wonderful questions and answers that Carol Brinkman has sent in and Lisa has sent in. One of the first things that we're going to be doing are case reports, and Carol sent in a number of case reports that help us dive into a number of issues that we hope will help you be better practitioners. If you have questions while we're going through this, please let us know. We're also going to address, as Lisa asked, a fabulous question because A4M is now teaching that every month you should take a 5-day hormone holiday. Is that accurate? Is that not accurate? How do we do or should we do hormone holidays for perimenopausal women, postmenopausal women? Who benefits from them clinically and in the science? We're going to discuss that, and of course, don't forget to ask more Q&A. So diving right in, so that we can cover a lot of ground. First of all, she says Becky is 42-year-old female who struggled with transdermal progesterone, tried for a year, and never could find the right dose. When she would titrate up, she got headaches. I had her stop the progesterone and start hormone balance and protect and receptor detox, and she titrated as recommended and tried over 3 months, and she got worse. She got tired, she gained weight, and she started to wake up a lot at night. I would have already suspicioned Carol right from the get-go that she was reactive to progesterone. So if you give her hormone balance and protect, her own progesterone is going to signal better. So if she's already not handling progesterone, we've got to figure out a way, if that is accurate, to test her and desensitize her to progesterone and possibly other hormones. And I'm going to go through some of the science with this with you. So after she didn't respond well to my new products, she switched her back to Zymogen's FemQuil, but she remains iron deficient no matter what. If somebody is optimal in their fat-soluble vitamins and their water-soluble vitamins, but they remain iron deficient, you have to think several things. First of all, did you do a stomach acid challenge test? Because you need to be able to make betaine hydrochloride to reduce iron to its electrical bioavailable state. Also, to absorb iron, you have to have euthyroid functioning. I don't know if you realize that. That's why iron and thyroid have a lot to do with hair loss or hair growth. And you also have to have zinc, partially because parietal cells need zinc to make betaine hydrochloride, but you really need to, iron is dependent on zinc to be able to be ideally absorbed. If you don't have enough iron, you want to figure out if the parietal cells aren't working, because the parietal cells make betaine hydrochloride. They also secrete, along with the duodenum, cholecystokinin, which along with butyrate are the main initial instigators of digestion. So in essence, stomach acid is the first domino that tells the gallbladder to contract. Cholecystokinin goes to the gallbladder and says, hey, contract. Cholecystokinin goes to the pancreas and says contract, and the pancreas secretes its multiple digestive enzymes. Betaine HCl isn't a digestive enzyme, it's an initiating digestive player. You specifically think of it if you are chronically anemic because you really need betaine hydrochloride to reduce all minerals to their bioactive electrical state, but especially iron. If you don't have good parietal cell efficiency, the parietal cells have a lot of aromatase activity, and they take androstenedione and testosterone and literally make estrogen. They make, in some women, the same amount of estrogen in the parietal cell that's made in the ovary. That estrogen is shunted over to the liver to detox. All hormones are processed in the liver. If the liver can't detox, the liver can't handle hormones. She might be reactive to progesterone because she has parietal cell insufficiency. So she really isn't shunting estrogen over to the liver so the P450 enzyme detox systems work, and the liver can't process the hormones. So her progesterone reactivity might not be true allergy. It might really come down to parietal cell insufficiency. So I'm going to ask you if you asked her that in a few minutes when we bring you up. But you said that when you checked her labs, she was lowish in estrogen, low in progesterone, and what we do know is 4.0 nanograms per milliliter progesterone protects breast tissue. We know this from breast surgery progesterone studies. And we know for fertility, you need to have about 8.8 nanograms per milliliter. So progesterone is breast protective at about 4 nanograms per milliliter, which she has 5.4 nanograms per milliliter. And it gets to be where it's more closer to luteal premenopausal functioning when it gets to be above 8 and 10. A woman doesn't have to come up to premenopausal levels to feel good. But if she's at lower levels and she doesn't feel good, then she might. So everything is in a dose response range with some outliers. So the average range of getting progesterone is 4 nanograms per milliliter to about 10 or 12, depending on the woman. So she could be lowish or maybe not lowish, but she still has progesterone in her. She tried taking extra exogenous progesterone and she got headaches. So most likely she has a low-level adverse effect to the progesterone she's got in her, and we're going to talk about that. So we either got to figure out why. Is it a parietal cell issue and it's really not anything to do with progesterone, or is it actually a hormone hypersensitivity? That's the new term for it. And I put all this in the slides, and I'm going to make these slides available as a PDF because you're going to want to go through them. And she's low in testosterone, and this also might be part of the issue because testosterone, remember, testosterone has everything to do with gut wall immunity. That's why men have a lot less out of the 159 autoimmune diseases, men have less of only one, the kidney autoimmune disease, autoimmune nephritis, and that's because testosterone boosts secretory IgA and it stabilizes immune activity in the gut wall. So men tend to have less autoimmune disease, but they tend to die more from COVID and die more from cancer. So each gender has their own hormonal weakness. But when you look at her labs, so I want to talk to you, was she on testosterone and what exactly was she on? So I have to ask you a number of other questions to get you the right answer. She has mildly elevated TSH. You know, we look more toward the free T3 than not. And I can't tell, you said free T3 remain low. So is it like 2.2, 2.5? What was that? We look more at the T3, but then if the TSH is above 1.85 and it's getting 2 plus and above, those two combined together give you even more stock in the fact that there might be hypothyroidism here. Now, if you have low iron and you have low thyroid functioning, remember, hormones are a family. It's really hard to get all of your hormones being properly absorbed and properly utilized. And if your liver, if you really have parietal cell insufficiency and your liver is clogging up, then it doesn't do a good job of processing hormones. So she could be having issues at a number of pillars of health that you have to kind of tease apart here, and I'm going to have to ask you some of these questions. She has a history of autoimmune thyroiditis, and her antibodies are elevating. So I don't know how much iodine you're giving her. That's something else I'm going to want to know. And she's eating pretty well. So Carol, can you get on?
Yes, I am here. And her last free T3 was at 2.4. And it actually hadn't changed from her last last appointment. And the TSH is on there. The free free T3 was at 2.4 and the free T4 was very low at 0.78.
So both of those are very low. Mm-hmm. So she really seems like she's hypothyroid. Is she on any thyroid replacement?
She is not. She is on iodine.
How much iodine?
I don't have that in front of me.
Okay. Dr. Brownstein has just agreed to give us in a few weeks, I think it's November 18th, the Friday Pro Talk, and he's going to do a deep dive into iodine and how you talk to other practitioners and what are the dosing. When I was shadowing him, he had quite a number of patients on 100 milligrams a day. Was really
Wow. Okay.
amazing. I know. So I said we got to have you come here and talk to the group. So I'm going to want you guys to send in questions for him. But hormones are a family. Now, have you done a stomach acid challenge test on her?
I have not.
That's the first thing to do
Okay.
when you have someone who's chronically iron insufficient. And remember, if you're iron insufficient because let's say that she went up to 3 capsules and then she had burping and discomfort behind her sternum. So then you'd say, okay, just take one. Take one 600, 650 milligram. They come, most of the capsules that you want to test with and want to give are 6 to 650 milligrams of betaine hydrochloride. The lowest one, if you've got someone really old and really friable, is Premier Research. I'm not in love with the company, but they have pure 400 milligrams of betaine hydrochloride, and it doesn't have any pepsin in it. I'm not a big fan of pepsin because in the one study where they tried, it's an industry standard to put it in with betaine, but it's not really been shown to do anything in the one study that took a dive look at it in the 1940s. And forward-thinking ENT docs have shown that it can aerosolize and worsen reflux and eardrums and lung issues. So just something to keep in mind. I like to get, Douglas Labs has 2 betaine products, one betaine hydrochloride and one betaine hydrochloride plus, and the plus stands for pepsin. You don't have to do this with the testing, it's not that important, but what if it was the one patient and how many that actually was aggravated by the pepsin and you would have considered it to be an HCl aggravation rather than a pepsin aggravation. So ideally, but you always, every single iron insufficient patient, you want to know, do they have parietal cell issues? And remember, not only that, that means if they have parietal cell issues and they can handle any support, they got symptoms at any level that you challenge them on, that means that the downstream organs for digestion aren't working optimally. And it also means that estrogen isn't going to the detox system in the liver, so hormones aren't going to work optimally. So that's going to be setting up a patient that doesn't give you the results you think you would want from hormones, but it's all muddy and murky, and you wouldn't know why. And that's really the problem when you look at all these things, are what are the most important things to look at, and how do you get out of a murk, and what things must you look at because they really influence. Otherwise, you just start giving, first you give hormone balance and protect, and then that doesn't work, and then you go to Femquil, and then you do this, and then you do that, and you're running after the symptoms, which we try not to do. And we claim allopathic medicine does. So it's always good to take each symptom. So the first symptom that you told me was that she reacted to progesterone. So she could either be truly active to the hormone, or maybe she's not processing it, or hormones are a member of a family, so maybe it's some other hormone. Remember, progesterone helps T3 nudge into the receptor. If you have problems with progesterone, you almost always have low T3. So they all interact. So the first thing is, do you have a true allergy? If you don't have a true allergy, is it something with the liver processing hormones? Is it some other member of the hormone family? If testosterone is low, and or if thyroid is low, you might have a really hard time having her respond to progesterone, and that might be the way that she shows up as she gets reactivity against it. But it's really a picture of a murky background behind it. So, because optimal D sounds like she's absorbing fat, so that sounds like bile secretion. And optimal B that sounds good. I always look at homocysteine to see how optimal somebody's B is. Because homocysteine is an amino acid. When it gets elevated, your IQ goes down a few counts, you get irritable. It's an aging molecule that causes aging symptoms. And really, it's kind of an easy demonstration. Does this person have enough B vitamins or not? Because B's, in most people, nothing in medicine happens all the time, and there's no set givens, as we know. But in most people, if you get B in, and let's say you give it orally, you give methylfolate and a backup B complex, and the homocysteine isn't coming down, then you give it injectable. And if that doesn't work, you give it an injectable in a different form or more often. Myself, I was taking supplements, and my homocysteine was creeping up as I hit my 70s. And then it went up to 15, and I freaked out and I started taking B12 shots twice a month. And within a month, it came down to 9. So it's actually often finding the right form of the B vitamin. Just to let you, is this helpful? Me talking like this, Carol? Are you there?
Yes, it's very helpful.
Okay, because I don't want to say stuff that you already know and I'm being
Oh God, no.
obnoxious.
No,
Okay, I don't know if
you're
I'm being obnoxious. Okay,
no,
God
you're
knows I
not.
don't
You're
want to
not
be
at all.
obnoxious.
You're not.
I was raised to be a good Jewish girl and not be
Yeah.
obnoxious. Okay. So,
Oh, okay.
so that's the first thing. She reacts to progesterone, but there's a number of things. And the other thing is it the base? The first thing I should say before anything else is, what can't does your compounder give a hypoallergenic base? Now, maybe you use hypoallergenic bases. I tend to use Versabase, or if a
That's what I
person
use.
Okay, so Versabase is pretty hypoallergenic. So that's
Hmm.
already if that's a hypoallergenic base. Once in a blue moon, if it's a really sensitive patient, I'll say, will you stick some probiotics in there? Because probiotics make it even less reactive. So that's a little trick. And you can
Okay.
ask your compounder to use as, like a binder and incipient. They just put in some probiotic granules in there. This is the good thing of me lecturing for PCCA is I hear all these little tricks that they do. Plus, they're one of the best companies on the planet, and compounders are some of the most wonderful human beings on the planet. But anyway, so when you say that she's not responding, what about the base? You can also make the base more hypoallergenic by adding more probiotic. But is she truly reactive to progesterone? And I'm going to show you some ways that this is something we got to get on this. I got together with an allergy company in Austin named Curex, because Jonathan is no longer constantly there's changes going on at Meridian, and for the last 10 years I've been using his long distance desensitization, and they've been working on every single patient that I've had. I just had my first patient that they did not work on, but there's changes going on there, and they're no longer taking on any new doctors. They're only keeping their old accounts. Dr. Brownstein uses the NAET, but I thought, God, we got to come up with something else and that people can use more easily, that they don't have to go somewhere to get it done. So I got in touch with this allergy company called Curex, and they worked out a progesterone patch and they put it on the patient for 48 hours, and it did not pick up. We've done it now on like 12 women, and it didn't pick up sensitivity in any of these women. I don't trust that as this skin test is working for us with this. So I'm on the hunt for some way, if you don't have NAET available to you, or if you have your own energetic machines or muscle testing, but I don't believe on basing everything on muscle testing. I like to have some kind of machine evaluation. But we're going to talk more. You can be allergic to any hormone, progesterone, any individual estrogen. Cortisol is a highly reactive hormone. Androgens, oxytocin. I just had a patient who went on oxytocin for migraines, and it gave her the worst migraine of her life. I just couldn't even believe it. And we tested her and desensitized her for other hormones. We didn't add oxytocin to the bunch. Then we went back and looked, and we desensitized her for testosterone. And when she went on testosterone, we had her wait now 2 weeks, not be on the oxytocin, and the testosterone gave her a migraine. Of course, a lot of things give this woman a migraine, to be fair, but nonetheless, it turns out you could be allergic, and we call it now the sex steroid hypersensitivity syndrome. That is the new name, sex steroid hypersensitivity syndrome. And the reason is I went into the literature that I have in your slides when I was trying to find out what scientists were thinking of why this is on the increase. Food allergies on the increase, peanut allergies on the increase, hormone hypersensitivity syndrome is on the increase. Why? And all of them said endocrine disrupting exposure in utero and prenatally, that estrogens and androgens have receptors and progesterone on every single immune cell, and they are immune modulators, and they make people now as they get older have poor responses to hormones. So it's too bad a lot more pregnant women didn't have hormone balance and protectin receptor detox when they were planning a family. But nonetheless, we live in this toxic planet. So you look at the base, you look at the hormones, you think of the hormone family. Then remember that in every single binding site, it's very real that you have a whole bunch of nutrients. You digest nutrients so that your most powerful signaling molecules, your hormones, can work. So you need zinc, and you need B6, and you need magnesium, and you need iodine, and you need vitamin A, and you need all of these inside the receptor. So if you're not digesting well, so iron deficiency that's chronic is usually a sign that you're going to have zinc deficiency, because both of them really need a lot of betaine hydrochloride to be digested. Zinc, iron, and magnesium need more betaine hydrochloride than any other nutrients. Now, you also need betaine hydrochloride to absorb B vitamins. So she is absorbing some B vitamins, but some can get absorbed water soluble, and some could be absorbed actually with digestion having something to do with it. So one, I would do I do the stomach acid challenge test now on everybody, Carol. Everybody, because it's so helpful. And is she on, what hormones is this woman on? If you took her off progesterone, is she on estrogen and testosterone?
She's not on any hormones right now.
So I would want to figure out what's going on, but on a person who's reactive like this, I try and test all the hormones and desensitize whichever ones I couldn't. And let's say you have no access to that, and you don't feel confident in your muscle testing to do that. The hormone I would start out with that is the most calming and anti-proliferative and stabilizing is testosterone. Because I know your question was you're struggling about giving her estrogen without progesterone.
Mm-hmm.
But you can give estrogen with testosterone. It's breast protective.
Mm-hmm.
And in the reanalysis of the Women's Health Initiative, all they gave those women was Premarin. And those women that were on estrogen, on Premarin, had a 23% decreased incidence of breast cancer over the next 20 years. From the time they did the test to the follow-up, it was 19 plus years. And they had a decreased incidence of fatality of 44% if they did get breast cancer. They died from it almost 50% less. So those are women that were only on estrogen. So I'm much more comfortable these days if a person can't take any other hormone, although we've got options. It's more important to have estrogen than it not being opposed, because so in the new NIH 7 million Medicare women study that you all got a PDF on,
Mm-hmm.
that study looked at 7 million women of who about 10% were on hormones. Depending on the timing, some people dropped out as they got a little bit older. But 10% of 7 million is about 1 million women, right? That maybe 800,000 women. And they all had statistically less. They were only on estrogen. A few of them were on progesterone, but the majority of those women were on solo estrogen. And they had statistically less all of the 5 cancers they looked at: breast, uterine, ovarian, lung, and colorectal. And they also had 20% less premature mortality, and it was mostly estrogen. So this old thought that we've had, I mean, we like to keep estrogen optimally functioning, but we used to think it's this bad player that's got to be policed. We used to call progesterone the policing molecule. But now we see it doesn't really need to be policed. That when you just give conjugated equine estrogen, which blocks ER beta, one of the quirky things of Premarin is it blocks ER beta. I mean, we've thought it's not a great player. Those women had much less breast cancer. So you can give a patient, if you try everything else, with more peace of mind than you ever had before, now that all the science is coalescing, Carol. You can choose to give estrogen without a modifier. But testosterone is extremely modifying. And so, what I'm doing on some very reactive patients, once I ferret out, and I'd want to deal with her thyroid because maybe her progesterone won't get healthy till her thyroid, and it's a two-way street because progesterone does nudge T3 into its receptor. It's remember they're promiscuous together as a family. So, and remember progesterone and oxytocin are made at ovulation together. So I think there's even an intimate role of progesterone and oxytocin. So in my mind, I'm always thinking with every single patient that comes in, and I know that's why I take more time and you guys don't have as much time with each patient, but I'm thinking of their insulin, their oxytocin, their this, their that. So if they have an issue with one, I'm trying to keep in my head at least check off the boxes of what I think about the other hormones. But the first thing to go to with this is it reactive against progesterone, and what about that parietal cell efficiency? You know, if a person has insufficient estrogen coming from parietal cells to the liver, over time this contributes to fatty liver. And 1 out of 3 American adults has fatty liver. And if you have fatty liver, you don't process your hormones right. Your liver's filled with fat. And it might even be filled with fibrosis and some scarring. A FibroScan would pick that up. But if you have chronic iron deficiency anemia, you have to think to yourself, does this person have fatty liver? Because that, if the parietal cells weren't working, you test it out and they can go to 3 or 4 capsules with no symptoms at all. They might be achlorhydric. And that liver might not have been getting estrogen. Estrogen helps keep a liver from becoming fatty. The liver is filled with estrogen receptor sites. Estrogen is the liver's best friend. And its whole detox that we're always talking about, detox, those P450 detox HEPA filters, so to speak, run on estrogen. So now a blood spot of estrogen at 49, if she has estrogen insufficiency symptoms like crepey skin and fatigue and losing memory, that's a good one with estrogen, and weight around the torso. Memory is a big one with estrogen, and sleep and hot flashes, those kind of things. Then 49 is too low for her. But if she doesn't have those symptoms, it might very well be that 49 is okay for her. The dose range of estrogen in a woman is 0.6 to 0.8 milligrams of 0.6, 0.8 milligrams of E2 to 2.6 milligrams of E2. That's a typical dose response range for women. And then there's some outliers that won't get their cognition back, or won't get their bone density back, or won't get their neurotransmitter balance status back unless you get the estrogen to a higher level. So some people need more, and some people are so sensitive they need less. But if she is 40, how old is she? 42. And so she still has her uterus, right? Is she still?
Yes, she still has her uterus.
Okay, so she's not menopausal. She's perimenopausal, right?
Correct.
Okay, I forgot that for a second.
Yep.
So, what do you know? What time of the phase that her blood spot hormones were done?
Her luteal phase.
Okay, so luteal phase. Now she's menopausal, so it's going to be perimenopausal, so it's going to be up and down. But in a normal luteal phase, the progesterone should go, almost to 9 and higher, 9 to 15 nanograms per milliliter. It should be higher. So, and a perimenopausal woman, and the testosterone should be a little bit higher. So and there's always a question about giving a woman who's perimenopausal, who still has estrogen, should you give her any estrogen at all? But is she using her own? One of the first hormones to give to these women, especially if they don't handle progesterone, is testosterone, because it's stabilizing, it increases the quality of life, it increases bone loss, and it enhances bone density. And, the first 5 years, she's not in menopause yet, but she's building up to it. So the 10 years before menopause or perimenopause. And I think you start to lose some bone density, you start to have adverse cardiovascular changes. And in the first 5 years of menopause, those are the worst of almost the whole time of menopause. So if you can get hormones balanced and kind of set, if you can protect that first 5 years and balance out the perimenopause, you actually can help that woman with her life more down the road. So now and she's had a history of autoimmune disease, which is worsening. Now, mind you, the first thing you do, autoimmune disease worsening, what would be the hormone you would think of?
Sorry,
Carol.
can you ask that question again? I got distracted by a question that popped up.
Okay, cool. So, being that her autoimmunity is worsening, what would be a hormone that you consider she'd be a great candidate for?
I'm not sure.
Well, testosterone. So, testosterone keeps the immune system from being on overdrive.
Okay.
It is one of the most. So, when you have autoimmune disease, you think the immune system is on overdrive, especially in the gut. You think of leaky gut, overdrive autoimmune system, and what men have much less autoimmune disease because they have more testosterone, so their immune systems don't tend to be on overdrive. But that makes them more susceptible to acute infections like COVID because they don't tend to be able to launch that huge first, IgM response, that first Th1 IgM response, and that is very androgen. Um, excuse me. So men do better at launching that first response, and women do much worse because they have less testosterone. So what is autoimmune disease but your immune system on overdrive? Testosterone has the personality of being a stabilizing hormone. It keeps the immune system more stable. It tamps it down so it's not on override. It fluffs and plumps up the immune system in the gut. Every time you think of any autoimmune disease, where does it? We theorize in functional medicine. Nothing is for everybody, but we theorize it starts in the gut with a leaky gut, and you get unhealthy bacterial translocation across the leaky gut wall, makes debris in the bloodstream that tells the immune system to go on overdrive, and the immune system seeks out a specific tissue, and we name the autoimmune disease for the tissue that it's in overwhelm attacking that tissue, because in actuality it started from the gut because the gut was on overdrive because there wasn't enough testosterone. So we're starting to think that one of the really great hormones to give in perimenopausal time is testosterone. So I would want to know her stomach acid challenge. I would want to, and the other thing with thyroid is, remember, all the hormones are a family. The ideal range of free T3, which is the real sweet spot of thyroid signaling,
Mm-hmm.
is 3.5 to 4.5.
Yep.
So she's at 2.4 or something like
Yes.
that.
Yes.
So she's got wiggle room. She would even have wiggle room to go on T3 at 3. We used to talk about this a lot at the Wiseman Family Clinic. And it's hard because if you draw blood every single day, there's some fluctuation up and down of these numbers. They're not set in stone. But you said at her last labs she was T4 for free T3. You said it's been replicated now a second time. But
Mm-hmm.
so this is a person. So let's go to the next slide that I put together. First, I would do hormone sensitivity training. I would start with testosterone replacement once I felt I would do the stomach acid challenge test and see if she needs betaine hydrochloride. And I would also really, is she a big woman and does she have big breasts?
Yes.
So one thing that David used to say, the bigger the body, the more iodine you need. Iodine is a transcriptional cofactor in every single, the two things that are on every single binding domain are vitamin A, the retinoic acid receptor, and iodine. If a woman is bigger, she might need 12.5, she might need 25 milligrams. The next level of identifying how much iodine you need is with the breast size. Does she have large breasts?
Yes.
So the larger the breast, the more iodine you need for that woman to really function with her hormones well. So there's a case to be made, and there's so many things to look at. There's a case to be made to add in any one new thing once every week or once every 10 days and see how she does with that one thing.
Okay.
So the first thing I would do is the stomach acid challenge test. I'd get a sense of parietal cell efficiency. I might run a fiber scan of the liver if I think there's that. If you had availability of hormone testing, if you don't have hormone testing, you don't have any way of doing any of that, just forget about it. And I'd consider giving testosterone to this person. You don't start with estrogen in a perimenopausal woman. She's still making estrogen. Her level was not really high, but it wasn't terrible. I asked David, what levels do you go by with estrogen for a postmenopausal woman? He says, I just want to see it in there. It can even be at 25. Whereas, David Rosensweet is much more specific than that. But nonetheless, I would also look at, if you can get to the sweet spot of iodine, you start to make hormones really work. When I was talking with David Brownstein 2 nights ago, he was checking in on me. He's such a sweet adopted brother. He said if the FDA came after me and I only could do one thing in practice, the one thing I would hold on to was iodine, because it's been the biggest game changer for me, but at much larger doses than anyone says. So I invited him to come on, because every time I tell a patient about iodine, they go off and talk to their other practitioners who scare the heck them out of what I've recommended. So I wanted David to come on and talk to us about what's the way to say it that it can really be understood, or what are the pitfalls when you get a lot of flack from intelligent, caring other colleagues. So what do we do with that? So anyway, the other thing I wanted to tell you, if you go to progesterone and allergy in PubMed, I did this morning, there's 656 results, many of them around autoimmune progesterone dermatitis. So progesterone is the most well researched, most highly hypersensitive hormone of any hormone. We don't totally understand why there are anti-progestin endocrine disruptors. We don't know if that's playing a role, but this is well established, but you never hear anyone talking about it. And most of the time when you get negative reactions to hormones, it's very commonly progesterone. So you can say to women, progesterone is, you can be allergic to anything, to any hormone. But the hormone that most commonly can have an adverse reaction is progesterone. And at this time, we don't have a way to desensitize you, or maybe you want to work with a local allergist and figure this out. I'm really going to try and work on this, because I think we're seeing this more and more. David used to tell me he never saw it. Now he's telling me he's seeing it here and there, and he used to never see it for decades. And now he's seeing it on a somewhat small but regular basis. So this is important to know. And the condition autoimmune progesterone dermatitis is an immune disorder. It's mostly in women, mostly due to progesterone surge in the luteal phase. And here they presented a case of a 29-year-old female with recurrent severe skin eruptions. So they call it autoimmune dermatitis, but then as you go and start reading through the studies, they go, well, not all cases show up with dermatitis. It could just be that a woman doesn't feel well or has headaches, like in Carol's patient case. So we're even thinking of taking off the term dermatitis from it, but that's what it has been caused to. But she had blistered skin lesions and of the mucosa, and they were treated with steroids and antihistamines for symptom relief, and then encouraged on the birth control pill, which is not something we would do. But this is just telling us, and here's some interesting things about the menstrual cycle. Represents the opportunity to study the physiologic effects of hormone fluctuations on immune function, and reports on the effect of the cycle on immune cell numbers and activity fluctuations are scarce, but recent publications demonstrate that this is starting to pick up speed, and this is in 2012. And it says that most of these diseases display worsening of symptoms premenstrually or during the menses due to physiologic effects on the target tissue by either progesterone and estrogen fluctuations. And this one, and that article came from Brigham Young and Women's Hospital, the largest teaching hospital from Harvard and Boston, and a Permanente group, and they talked about reactivity and immunology. This is a hot area that just hasn't been taught in med school. And hormones are going to become more and more popular. They're going to become their own board certification in some way. You guys are going to be pioneers in the field. Everyone's going to be looking to you because not a lot of people really get hormones. They're really a deep dive, that's for sure. But COVID put it on the map with its role in immunology. And it says here in the following review, the current knowledge about the modulatory effects of the menstrual cycle on both immune cells and systemic diseases like autoimmune, asthma, diabetes, cardiac, and schizophrenia. I mean, hormones have, they've been relegated to the endocrinologists and gynecologists, but they have a lot to do with everything. So if you have any autoimmune patients, you want to think of testosterone. And you also, of course, want to tighten up the gut wall, but all hormones can be off. Now, it may very well be that one of the biggest things for treating this woman is getting her on betaine hydrochloride. It might be that her parietal cells were really insufficient. Of course, you better, if she does have achlorhydria or hyperchlorhydria, you got to rule out H. pylori, because H. pylori is a chronic bacterial infection that produces ammonia and makes the whole inside lumen of the stomach alkaline, and you can't digest. And it can take up to 2 years for the parietal cells to recover after one H. pylori infection. And in some people, the parietal cells never recover. So once somebody's had an H. pylori infection, they need to get a stomach acid challenge test like once a year, and they need to have family members tested because it's an extremely contagious disease, and it can play a role into whether nutrients are absorbed that allow hormones to dock and bind and deliver their signals. So it's really, parietal cell efficiency and having no pathologies in the stomach are really important to figure out, and especially a person who's got issues. This is the article. It's called Progesterone Hypersensitivity Syndrome. This is the name of the syndrome, and it was published in Current Allergy and Asthma Reports. Is this the next one? Excuse me. I think this is the, whoops, I think that it was from this group. It was from Harvard. This is from this next article affiliation list. So this article, so Harvard, Brigham and Women, I never can pronounce this right. So Brigham and Women's Hospital. I don't know why I always want to put Brigham Young from the Mormons in there. They say progesterone hypersensitivity is a rare disorder which usually occurs in women of child age, and it could have multiple organ involvement consistent with allergic anaphylaxis to a spectrum of non-evanescent skin eruptions. And they propose different diagnoses, but they say it's recently proposed to use the progesterone hypersensitivity to replace autoimmune progesterone dermatitis due to the lack of evidence supporting an autoimmune mechanism for this disorder. Women, for some reason, we're not exactly sure, and they start discussing exposure in the womb to endocrine disrupting compounds that are setting up abnormal reactions to hormones that you would normally function symbiotically with as you become an adult. And they say the spleen is also involved, that there's a biologic effect of progesterone mediated, I never had heard of this protein, 34kDa, which basically helps, it's a protein that really helps keep progesterone zen, and it's made in the spleen. And if this protein doesn't work well, progesterone doesn't stay as zen, and endocrine disruptors in the womb, like DES offspring, are known to not make a lot of this protein. And that's why they had more breast cancer in their 40s, most likely, is because they had less progesterone, because they had this endocrine disruptor and they made less of this protein, so they couldn't keep progesterone. I'm theorizing all this and connect the dots together. But there's also a lot of discussion about estrogen allergy. It's not only progesterone. Food allergy and other types of allergies are becoming epidemic. A large portion of information in the literature says that xenoestrogens can regulate the immune response in general and in specific with allergies. and they talk about xenoestrogens as increasing the incidence of um, of not handling hormones as well. And I don't know if you're starting to see a pattern where I really think we should these days start giving estrogen replacement to some young girls. Would PCOS patients be better if we gave them a patch of estrogen? And gosh, I wish there was a patch of progesterone that would be part of that estradiol patch. But I'm really thinking that hormones are moving younger and younger, possibly because of all of this. And here was an article: estrogen was suggested to be involved in progression of diseases such as asthma, allergic rhinitis, and this came from xenoestrogen regulation of food allergy. So I just wanted you to know that hormone balance and protect and receptor detox are really important to put on. But I think that Carol's case shows us is not every patient will be fixed by that, because there's too many underlying issues. Hormone balance and protect helps keep our hormones more level. So if this woman's now having even more level progesterone and she didn't handle it well, then it might make her worse. So that's kind of interesting. Here's, I thought, was a really great, this came from that Brigham Brigham Hospital Harvard study, estrogen regulation of food allergy. And here's the possible targets for xenoestrogens. It could be the skin, it can be the regulation of pepsin, and enterocytes bind to estrogens. So the whole gut wall is ruled by estrogen. And mast cell proteases and intestinal immune cells and dendritic cells and Treg cells, those are all run by estrogen, progesterone, and testosterone. So with Carol's patient, I do the stomach acid, I would look at the thyroid and all the other hormones, and I'd give testosterone, and I'd probably up the iodine before I gave thyroid, but it wouldn't mean that I would rule out thyroid. So Carol, does she have thick eyebrows all the way to the end?
That's a great question that I don't remember.
And the other thing is,
I mean, I look at that with all of my patients. I just don't specifically remember that with her.
okay, does she have really dry skin?
No.
Okay, is her hair thinning in any way?
Yes, her hair is thinning.
So, hair thinning can be many, many things. But the
Right.
first thing you think of is low thyroid.
Mhm.
The second thing you think of is it's a quick turnover of digestion and amino acids. It's made of protein. And the other thing you need stomach acid for is not just minerals, but you need stomach acid for protein. So you'd want to look again at a stomach acid challenge. You might want to look at giving her some amino acids in the morning if her albumin is not above 4 and if her protein in the blood is not in the 7s. Protein in the 6s tells you they're not absorbing ideally, and albumin that's 3.9 or something, or maybe 4.1, because it should be the most abundant protein in the blood. So those are just some things to guide you a little bit. So why did I put this in here? I think I'm going to have you read this, but I'm going to move forward. So why did I put this in here? So during childhood, boys get more asthma and atopic dermatitis, but as soon as there's puberty, estrogen plays a bigger role in women, and women start getting more adult onset asthma, and they start getting more autoimmune diseases. And there's a significant positive association between sex hormones and adult onset asthma. And in an epidemiologic study of more than 100,000 nurses, this was reported, and I wondered what was a significant positive association between treatment with sex steroid hormones. So that was probably treatment with birth control pills. So then you have to ferret out that, but I just wanted to put this in here. So prenatal events appear to be crucial in programming the infant immune system. There's a high window of risk for allergic sensitization, and we used to think this is mostly of peanuts and dairy and soy, but now it's turning out that it could also be to progesterone and estrogen, and we really are seeing more people that can't handle the hormones they have. And then they have a terrible American diet, so they don't have the nutrients and the receptors. And it just crescendos as to how much they've got going on. And then the liver gets fatty and can't process the hormones at all. So you got to figure out in a patient. Most patients now coming in have many of those things. So how do you figure out which is the most important thing to do? So you almost always first want to look at the gut. And with autoimmune disease, you always first look at the gut. And the gut, you got to heal the gut wall. You got to identify any infections in there. You got to make sure there's stomach acid. You got to look at the parietal cell. And you got to look at testosterone because it tamps down autoimmune and it enhances the gut wall immunity. So these are things now that you can start thinking of. Estrogen there's a estrogen hypersensitivity syndrome that we think is because so many exposures. So if we don't have the OBGYNs saying, hey, this is exciting, let's start educating women who want to get pregnant and are pregnant, and reducing exposures and eating less pesticides and wearing less phthalates and not microwaving food and plastic and stuff like that, we don't have any of that going on, and we're having more hypersensitivity hormone syndromes that are starting in the womb. So now always differentially diagnose this in your brain, especially with birth control pills. This is an association of maternal use of oral contraceptive pills before birth with a high risk of atopic diseases, asthma, allergic rhinitis, and atopic eczema in the offspring compared to women who had never taken hormonal pills, because birth control pills are endocrine disruptors. So always ask the patient, was your parent on hormones or birth control pills, or have you been on birth control pills yourself? The other thing is, what was the sex hormone binding globulin in that patient, Carol? Do you remember?
I do not have that on my sheet right here. I always check that, but I did not write that down here.
Okay. Anyway, I thought I would let you know this is an article, a bunch of articles. Additionally, long-lasting immune modulatory effects of DES exposure have been seen. Exposure in utero just for the first 5 days after birth um, delays the hypersensitivity responses, but studies with small numbers of DES daughters have suggested fluctuation in killer cells, hyperresponsive immune system. They have more autoimmune diseases. They have more asthma, arthritis, lupus, diabetes, etc., and they tend to be fatter. So remember that DES was sold in many prenatal vitamins, or it was sold with hormones that were similar to DES that cost less than DES, but hormones were thought to be the in thing to give to pregnant women, that they'd make a normal pregnancy more normal. So remember, it wasn't banned till 1971, and even then it was hung around for a few years because not everybody complied right out of the chute. So women who were born up to about 1975 might have had exposure to DES, and their parents might be eating steak that was all fattened up in the feedlots with DES. So that was there's a lot of people coming out that are adults now that probably are reactive to hormones. So these are some of the other names that it was under. I think there's altogether Sybil Shainwald, who was a lawyer that helped women sue, and she was in New York, and she helped me with, I was a member of a class action suit, and then I helped her with the breast cancer. I came up with the idea of its link to breast cancer and kind of championed it, and I had already signed off on a class action suit, so for, not very much money, and now breast cancer patients, if they can prove it all, can get up to $12 million for breast cancer. And so when I was working with her, she told me, she made her whole career DES, that there were about 365 different prenatal vitamins at the time from 1938 to 1975 that contained DES. All those adults might have issues handling hormones today. So it's something that's coming down the pike, that's huge, that's happening, that we're understanding now some of the connect the dots, but we don't know what to do about it if we don't have access to testing and desensitization. And these are more ways of looking at it. So anyway, in general, pesticide exposure causes a decrease in alteration in cell-mediated immunity and more antibody production. That's what humoral immunity is antibody production. So pesticides contribute to autoimmune disease. So, but she already is eating an anti-inflammatory diet, but I don't know if it's a pesticide-free diet. Is it?
Yes.
Okay, that's good.
Yes.
I don't know why I have some of these in here. This is from St. Jude's. Matters of life and death, how estrogen and estrogen receptor binding to the immunoglobulin heavy chain locus may influence outcomes of infection, allergy, and autoimmune disease. And this is really how sex hormones completely influence autoimmune disease. They happen, 9-1 females to males. And they basically say it's because of sex hormones, and then they go on to write about endocrine disruptors. And this is from St. Jude and all the scientists, and they all work there. They're all passionate people. So you have to figure this out then in your patient. And then here's one that I just threw this in here because it was with polycystic ovarian syndrome patients, and they gave them vitamin D, and this study supports beneficial effects of D-supplementation on liver markers and moderate improvements in insulin sensitivity. So, and there's another study that says that D helps testosterone work better. So don't forget to think of D as a member of that hormone group. So I don't know what her vitamin D level was. I don't know why I put some of I completely put this together, and for some reason now I can't remember why I put this in here. Testosterone supplementation. This is
Yes.
what it does for men. And it does so many things for men, but I don't see any reason it wouldn't do the same things for women. The big thing is it reduces fat on the torso. And that's one of women's worst complaint. It helps with blood sugar maintenance. It helps with fight sarcopenia and maintain muscle mass. And it is a hippocampal revolumizer like estrogen is. So testosterone, Carol, I'd look at the thyroid, I'd look at the parietal cell, and then I'd kind of contemplate inching in, and I'd give testosterone, like depending on her sensitivity to things. It's real hard for some compounders to do a 1/4 milligram, but they could do a 1/4 milligram or they could do a 1/2 milligram. And then I'd give it to them like let's say you're going to give her a 1/2 milligram. She's not as sensitive as that. And
You know what's so interesting is that her testosterone level was normal the first time that I checked it, and last time when I checked it, it was almost non-existent.
So how long ago was that last lab test?
September.
When you're perimenopausal, all your hormones are up and down. Is she having really heavy bleeding and clots, or what's her cycles like?
Her cycles are irregular, and they really are pretty much all over the place. Sometimes they're heavy, sometimes they're light.
So she's not making any progesterone.
Correct.
Except, you make a little bit in your brain, a little bit in your heart. So I don't think the hormone balance and protect should have been hurting her in that way, but I don't think she's handling her hormones well.
Mm-hmm.
But I'd first want to look, is it a stomach acid thing? I'd want to make sure she doesn't have fatty liver. And probably the first hormone when I do decide to give her hormones, and I think that all the nutrients, that she's got enough iodine, and maybe I want to put her on 50 milligrams of iodine Monday through Friday for a month, and then maybe go down to 25 milligrams for the next month, and then down to 12.5, and ask her to feel how she feels different at all those levels. I'm starting to do that now with a lot of patients. And those are the things you think of, which one you want to do. Do you want to do the iodine before the testosterone? I probably would. But the first hormone I'm going to think about with her, and especially if she's not feeling better with anything, let's say she's low in stomach acid and I put her on it and it really doesn't do anything for her. So then you go on to the next thing. So you have a list of, I don't know if that makes sense to you, if this thinking is new to you, or.
No, that makes sense. And did you say Monday, Wednesday, Friday with the iodine?
No, Monday through Friday.
Monday through Friday. Okay.
That's what I've been doing now. Now, when I was at David's, he gives a lot of people are on 25 and 50 milligrams of thyroid. He had one guy that was his whole family had goiters, and he had a goiter, and then he was on 100 milligrams a day, and he felt fabulous. And if he went below that, the goiter would start coming back. And he was a small guy. He wasn't really a huge guy, which is really counterintuitive. But you have to kind of consider that I can't wait for David to really talk about why he thinks it's really safer. And I know it's based on Abraham's work, but nonetheless, it makes most people very uncomfortable. I just had a patient that I've been seeing for a number of years, and she's been doing great. Perimenopause had horrific autoimmune diseases, but is doing better than she's ever done. And then she reached out to me and said, I got to talk to you. And she said she's doing terrible. She has a dry vagina. She has dyspareunia, and she's gaining weight and nothing feels good. So we keep probing. How much iodine are you on? She goes, oh, well, I'm not taking it anymore. And I said, well, since when? Now, her symptoms have all been for 5 months. She said, well, about 6, 7 months ago, I started listening to this male naturopath. And he said iodine is the enemy of the thyroid, especially if you have autoimmune thyroid. No one with autoimmune thyroid should be on iodine at all, and you shouldn't be eating fish, and you shouldn't have iodine in any of your supplements. So she said, I've been religious about it, and I've been avoiding iodized salt, and I've been avoiding fish, and I've stopped taking iodine. So that was like kind of a no-brainer with her, but it's interesting. So I really would like to know. I know David has said this before, but I'd like to hear it again because I can't really repeat how to allay people's fears when you've got somebody who's as famous as this going out. And you know, most of the allopathic profession feels that way about iodine. Alan Gaby feels that way about iodine. And Alan and David once had me act as a referee on a phone call between them because they screamed and yelled at each other because they both had such opposite viewpoints on iodine. But Alan hasn't really been in clinical practice. He spent his whole life writing that book and teaching, but he's not been in clinical practice and not around hormones. I thought this article was interesting that they discovered that basically T tamps down inflammation. So testosterone tamps down inflammation, and it suppresses antibody production. That's why it's helpful in autoimmunity. So whenever you think of some patient, your patient's antibodies are getting worse, she's really going to need testosterone sometime sooner than later, because it's going to probably be the hormone that makes her feel better without reactivity, and it might help get rid of her autoimmunity and inflammation and make her feel a lot better. There can be a case made, let's say her stomach acid challenge test comes back where she doesn't need any. So that whole theory of estrogen going to the liver has nothing to do with this person. We might just want to start her with iodine and testosterone and see how she does. It all depends on what comes back in some of these things. But this was really interesting. This was a study in Puerto Rican youth, and it was called Testosterone to Estrogen Ratio and Lung Function. And they wanted to evaluate a change in free testosterone to estrogen ratio and what that did to lung function. And for each time that testosterone, and you had a patient whose lungs weren't responding, each time that the testosterone went higher in ratio to the estrogen, the lung function improved. So the COVID studies have been showing us progesterone is helpful for lung repair, but it might be if you're not getting the response with progesterone, you might want to try it added to progesterone or just testosterone, depending on the specific patient's case. So you want to test and desensitize if you can. You want to balance all the hormones and perhaps start T, because T reduces pro-inflammatory cytokines, and keep this in your head. T reduces antibody production. Any antibody, Wernicke's granulomatosis with fibrosis antibodies in the lungs, mixed mucosal collagen disease. It doesn't matter which antibody. It lowers antibodies. So this is a good thing to know. Is that helpful, Carol? Do you have any other questions? Oh, there's some questions here. I better look at some questions.
Very helpful. Thank you, Lindsay.
I've got so much more to go through, but let's see. I am on call and hopefully my phone will be quiet. Oh, okay, sorry. Thank you for being here, Carol, and asking these questions. I'm interested in discussing the best protocol for long COVID. Well, this is something else. Okay, thank you. But we're not going to talk on that tonight. We'll wait till Dr. Gallen gets on, but we're excited to have him.
I'll hold that question for that talk, Lindsay. I've captured it for that.
Okay. Is it safe to take Paxlovid several times a year for clients who get COVID? I have no idea about that. Why would anyone take Paxlovid? It has rebound. Apparently, the new mutations respond better to Paquinil, hydroxychloroquine. So, I don't know why one would use Paxlovid. It just doesn't seem, it has rebound. It doesn't seem to deal with it, so I don't know about that. I know that you can take ivermectin and hydroxychloroquine multiple times a year. You have to be careful with transient rises in liver enzymes with ivermectin, not in everybody, but if you're taking it like every time you fly, like I take it. And in the beginning, when I had COVID and I took it a bunch, it did make my liver enzymes go down, and then I did detox protocols, and it went, the next time I did my blood, they were back down to really in the teens again. So they weren't just low, they were low optimal. So we're going to talk about this stuff later because this is different. Here is a copy of the end. I thank you that, Chris Roche. Not sure if you received my questions. No, I didn't receive any of your questions, and we're not talking about COVID right now. I'm so sorry. I didn't receive any of your questions. Sarah, did you receive any of Chris Roche's questions?
She put them in the chat when she was driving. That's what she was referring to. And I responded back to her. So
okay, we're not talking about COVID right now, ladies. Sorry about that. Yeah, we're not talking about the spike protein right now. Sorry about that. So Carol had sent these in very dutifully and good a few weeks ago. We're talking about her questions, and we're going to go to Lisa, so I want to try and get to these. So did that help? Is there any other question with that patient, Carol?
No, ma'am. You answered my questions, and I feel like I've got a path that I am going to take with her. And she actually just texted me or emailed me today. And so I'm anxious to get back to her. Thank you so much.
Does that sit right with you, or is it not?
Oh, definitely. Definitely sits right with me. Everything makes perfect sense. And I am going to listen to it, this piece over again earlier in the day when my brain is a little bit fresher too, so that
I know the brain is not as fresh at night. I know.
Yeah. No, it's all good. It's all good. I just appreciate you doing this.
Okay, so this is a woman who's in her 80s. So think of that. She's in her 80s. So she probably doesn't have any hormones on board at all. So the first thing you want to think, is she on hormones, Carol?
She was on hormones and felt like she wasn't really responding very well to them. And I did put her on progesterone for about 3 months because of the study with progesterone and COVID with this serious lung infection, but she saw no improvement whatsoever. And then we have a scarcity of infectious disease doctors in our area, and the two that are in my immediate area are, and they're terrible to work with, and they don't listen to people, and it's very, 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 very frustrating.
I just had a really negative experience seeing a doctor as a patient today. She was so rude to me and wouldn't tell me anything, and just was, and I had to see her because it was about my eyes just for my checkup. But she wouldn't tell me anything. And I went away just going, this is what I felt most of my life when I go to doctors, and I hate this feeling because doctors are such a love-hate relationship, or providers. And
Well,
that's what we're doing, is offering something that's so different, but it's how do we do this without wear and tear on us, right?
It's just it. I mean, I'm scheduling out for 7 months right now. A new patient has to wait 7 months right now because there's just not enough people that do what we do. And
yeah. Anyway, So the first thing you want to think of is maybe testosterone is a game changer for her.
When you started to talk about that, I immediately started to think about Sylvia because I saw her again today with a few other symptoms of concern that she has because she actually started the antibiotic trio that I name on here, and she got so sick and did not tolerate things at all. She has
Even
dropped
her
weight.
own doctors thought she wouldn't be a good candidate for that, you
Right,
wrote.
right, exactly,
You know,
exactly.
antibiotics get harder and harder to take as you get older. So I think that I would consider one, I'd look to see a stomach acid challenge because she might be in her 80s and not, no longer making stomach acid, or she might be the opposite. I make a lot of stomach acid naturally. I can't take betaine HCl at all. I make more HCl now than I did when I was younger. I don't know why, but I do. And the minute I take one's challenge, and most people my age need stomach acid replacement. So you have to test it. You can't just assume that just because someone's in their 80s doesn't mean, but she might need that. She might need testosterone. And she's also a great candidate, if she hasn't done it, for nebulizing glutathione. I mean, that's why Davis Lampson came up with that idea at the Tahoma Clinic, and he wrote a paper on it, on nebulizing glutathione. And it was for asthma patients and chronic lung infection. And all kinds, bronchiectasis. It could be a wide variety, chronic congestive heart failure patients. It could be many people who start having less great lung health as they get older. And you always want to look at the cortisol levels because elevated cortisol keep infections going, right? One of the symptoms of dysregulated adrenal glands are recurrent infections. And it could be too much cortisol or too little cortisol. So you want to run I like diagnostics, ASI test for cortisol levels, and you might want to give her testosterone, and you might want to check out her stomach acid. And it's always good to do food reactivities with chronic infections too. So you might want to run some food reactivities, but you could just start with testosterone and stomach acid challenge, and that might be and nebulizing glutathione. Have you nebulized glutathione with this patient?
I have not.
Have you nebulized glutathione much? Because it's coming into
No, I have
respiratory.
not. I have not.
So you should look up, I think it was published in the Townsend Letter, or it might be in another regular medical peer review journal. And it's by Lamson Davis. Yeah, David Brownstein just said he can't do the 18th, ladies, on that day. He said he'll have to do another day. We have to figure out a different time for the pro, darn it.
Okay, we can do that.
Okay, just to let you know. Well, it's sterile glutathione, and it has to be done by a compounding pharmacy that has a sterile hood.
Yes.
So we do it a lot here, and they usually give you a little dried powder, or it can be mixed up with the compounder where it's already mixed with liquid. So they usually give you dried powder and saline, and you mix it. Of course, the FDA police might come in and accuse you of compounding without a license. I don't know these days. It's so bizarre. But nonetheless, this is something to think about with her. And I would also think about, so she was on hormones. I would love to know more about the way she was taking the hormones in and the doses she was taking the hormones in. It could very well be, someone says they tried hormones, they didn't work. Well, one, you have no idea the dose of hormone they were put on. Maybe it was an estrase patch and it was in the micrograms, right? You don't know. Then on top of that, when you age, your sex hormone binding hormone goes up. So you got to do something to bring it down, or you got to take much more hormone. Estrogen and testosterone. What does sex hormone binding globulin bind up? Estrogen and testosterone. So you have no estrogen and no testosterone. So if it's really high and you take a small amount, you really, you don't get any bang for your buck. So you have to find out, or you have to try it again at dosages that that you're willing to titrate up to see if that might help her. But you tried progesterone, but it might very well be she needs to be on estrogen and testosterone, or maybe just testosterone. But I would want it, probably her levels of hormones are in the toilet. Is that true?
That is true.
And you don't remember what her sex hormone, do you know what her FSH is?
You know, I don't, because this was a more of a lung infection kind of thing. I didn't pull up her other hormones that she had done. One of the issues that I am fighting against a bit is that she has two daughters that are very anti-hormone, and she really wants to be on hormones, but she has her daughters talking just the opposite. So that's a
I
struggle.
just can't even believe that a grown woman would let her two daughters' opinions make her miss out on hormones. What's wrong with her? That is she that much run by her family?
Well, she can be. Actually, today she came in by herself, and she tries to do that as much as possible because she would prefer
Good for
to
her.
have her own decision making. And then, of course, I got messages from both of her daughters
Oh
after her
God.
visit. Yeah,
Oh,
I know.
I tell you, people don't get me started.
Yeah, exactly. Don't get me started either.
On one hand, you love people and you want to help them, and on the other hand, at the end of the day, sometimes you can't stand them and you go, I just can't do this anymore. People are driving me crazy and they're really mistreating me, and am I in an abusive relationship here with my career? What's going on?
Uh-huh.
Oh my
Uh-huh.
God. You got to ask yourself this is why straight doctors aren't doing what we're doing, because what we're doing looks so painful to them. Like David Brownstein said to me, how long do you talk to people? I said, I talk to people in the first intake an hour and a half to 2 hours. And he goes, holy God, what are you asking them? How many times can you ask them the color of their underwear? And I said, it's much more in depth than that. And he's just an old time doc and he asks very few questions. So you can practice functional medicine less detailed, but I don't see it necessarily getting, as many, I don't know. Everybody gets to choose which way they want to do it. So you can nebulize glutathione. I would also measure in her human transforming growth factor beta 1 and galectin 3 because they drive all fibrosis. And that lung issue has fibrotic components, mechanisms to it. So if human transforming growth factor beta 1 is elevated, whatever the reference range, all reference labs have such different reference ranges, I would give 1,000 milligrams of taurine twice a day. If it's like way off the charts, like some people have mold, it's a common test to run by environmental doctors because mold will also elevate human transforming growth factor beta 1, and it can elevate it really high. And also cancer. Both these cytokines, TGF beta 1 and galectin 3, they both drive cancer. They drive adverse remodeling. They drive all fibrosis is driven by these two molecules, and cancers are driven by these plus other things. But all fibrosis really comes down to excess of these molecules. Taurine brings down human transforming growth factor beta 1. If it's very, very elevated, you could go up to 2,000 milligrams several times a day. And modified citrus pectin lowers galectin 3, but sometimes you have to give really high dosages and it's expensive and it doesn't mix well with water, and the powder is of course less expensive than putting it in capsules. So it's kind of a drag, but you still need to measure these markers with someone with chronic lung disease or chronic severe infections because they might be part of it. And another thing to consider is whole blood ozone with whole blood irradiation. So they take 250 or 500 liters of blood out and they mix it with ozone, and then they going to drip it back into your body, and it goes through a glass tube that's in a machine called a whole blood irradiation machine. I had Naples buy this since I've been there because most of my adult life I try and do this once a month, do in the olden days, they used to always say the way to stay younger longer is we all have many infections in us, and we don't even know how to identify all the infections we have. So if we could have something that cleaned house on a regular basis, so they thought about low dose doxycycline and this and that, and they came up with this machine which uses UV light to kill spirochetes, Lyme, this, everything. It kills everything, but you only can do so much blood at one sitting. You don't do all of your blood in one sitting. And when I had um, Lyme, neurogenic Lyme, I did 40 treatments of this, but it's a really good thing to keep in mind with people with severe infections that you would normally send to infectious disease docs, but they're not docs that really like to talk to you or the patient or really interact. So you want to have more tools in the tool bag before you need to send them there. So anyway, that's something for you to think about. Does that make sense, Carol? Okay.
Yes, thank you very much.
Okay. So I think you're doing yoga over there on the floor when you're not. Okay. This is a 68-year-old male. He started on bioidentical testosterone with Chrysin. I'm not such a huge fan of Chrysin. I know that it's an aromatase inhibitor, but there are several articles that say that it's also a mutagen. So I like to use grapeseed extract, but Pam Smith has gotten everybody using Chrysin ever since she teaches it. It's kind of gotten popular. So I don't know. Just FYI, Chrysin has a few articles on it being a mutagen. His libido improved, achieving and maintaining erections is improved, but he's struggling to ejaculate and has diminished sensitivity on the penile head. He has a whole bunch of stuff going on. He's stage 3 kidney disease, got anxiety, migraines, hyperlipidemia, sleep apnea, and he's on a whole bunch of medications. He's on Lexapro and Trazodone, and an article came out yesterday. I don't know if I published it in Substack or not, but it was on, I don't think I published it yet, on how antidepressants after 10 years are causing a lot of serious health issues. They're not benign meds. And I've always thought that Trazodone was one of the very best sleep aids, but Trazodone came out as causing most of the antidepressants, and Trazodone came out to greatly enhance the increased risk of cardiovascular disease at 10 years and also cause earlier death, earlier premature mortality. So anyway, this guy's is on a lot of meds. And so one of the things I was thinking about, oh, that's a different patient. Why did I put this here? So why did I jump into that? Okay. I can't remember where I was going with this guy, so let me read this more a second. Start him on bioidentical testosterone, and he's got some improvement, but it hasn't gone all the way. He still doesn't have sensitivity. So where is he applying the testosterone? It's transdermal. Why
Yep.
don't you have him apply some of that testosterone on his penis head?
Oh,
We have women do it on their clitoris all the time.
True. I don't know why I didn't think of that.
Why don't you try that?
Okay.
Start with it like every other day, because it might end up being too strong. And if it's not, have him do it every day and really rub it in so that it gets picked up by the skin, or, kind of put it up and down the shaft. But that's one thing to consider right off the bat, is that some of his testosterone that you give him can be applied on the area that's less sensitive, because testosterone enhances sensitivity in men like estrogen enhances sensitivity in women, and he might need to get it right there. So that's a thought. And he's on all these medicines, and each of these medicines. So this is the deal. Protonox rinses out B6. That's why I had this here. Okay. I couldn't make the distinction. So every single time a patient's on a medication, you have to know a list of what nutrients are washed out by that medication. Because if they're not taking those nutrients regularly, then they're starting to get insufficient, and they start getting other health issues that are really actually due to old-time nutritional deficiencies. So that's,
Lindsay,
yeah.
do you have a good resource to look at what nutrients are flushed out by certain medications?
People's Pharmacy has a great um, poster on that. And I want the thing of it is the list is so big, but they have it kind of condensed down. So I'm going to go there and take a picture of it and do that because I got to go there and pick up some products anyway. But if you don't have enough B6, none of your hormones work. B6 directs how long a hormone sits on a receptor. It is the ultimate modulator of receptor duration. If you're B6 insufficient, it sits on the receptor longer. So estrogen dominance or excessive sitting on the estrogen and being bloated and gaining weight and heavy bleeding and all of that, that's insufficient B6. And you have to give B6. That's why the old time treatment of PMS was B6 and magnesium, because B6 is, they've known since the 40s and 50s that you need B6 to keep your hormones Goldilocks signaling the right amount at the right time. It's the important thing, and a lot of meds wipe out B6. So I started thinking, I called up Alan Gaby because he wrote one of my favorite books while I was putting the slide together, and I said, do you have any best favorite lists of the drugs that rinse B6 out of the body, because they all affect hormones? He hasn't gotten back to me yet, so I started putting it together myself. But B6 helps the action of all hormones. In this article, it's helping the uptake of testosterone. In fact, one of the symptoms of B insufficiency is you can't bring your testosterone levels up because it helps all hormones signal. And in this, it says B6 has a function in the action of testosterone and other steroid hormones. This is the words of these authors here. Possibly in the recycling of receptors from the nucleus back into the cytosol after initial translocation. So as soon as a receptor is used, it signals and it recycles. It signals and it recycles. And B6 dictates that duration. So you need B6 for all hormones. So if you might not know if that woman just was, when she took hormones 10 years ago, she was insufficient in B6, or she was taking a medicine that wiped B6 out. So remember, a ligand binds into a receptor, and B6 dictates how long this ligand sits inside this receptor. So B6 determines hormone docking timing. All hormone, cortisol, progesterone, estrogen, testosterone. It doesn't dictate oxytocin timing, but it still contributes. It contributes. It's critical to all hormones. So you have to take. Here's another one that a wide range of drugs from aspirin to estrogen. Everyone who's on estrogen replacement needs more B6 because you have more hormones, so you're using up more B6 to make sure that hormone signals right. So everyone on HRT needs more B6 or B complex vitamins, and B vitamins are critical for mood and concentration and for sleep. And if you're using a drug that depletes was something that Perlmutter wrote, depleting your body of B vitamins, you must take supplemental B vitamins daily, and you can use the homocysteine as an easy way to check if you're really absorbing your B vitamins. But so I thought, well, let's put together a list of what lowers B vitamins, and it was huge. Most asthma meds, budesonide, which helps people with a kidney autoimmune disease, but it also is given to everybody with inflammatory bowel because it's a steroid that works only inside the gut. And all of the steroids, dexamethasone, hydrocortisone, fluticasone, prednisone, anyone on long-term steroids, their hormones ain't going to work right. You got to get, that's why between receptor detox and hormone balance and protect, I've got an optimal amount of pyridoxal 5-phosphate, but you got to get it in some way. My products are some other way. Hydrazine, you treat high blood pressure, penicillamine, theophylline. I mean, the list goes on. Mount Sinai said drugs that lower B6, and they said tetracycline, a slew of antidepressive meds, monoamine oxidase inhibitors, and drugs for irregular heart rate, some of them, amiodarone. This is a big drug that's used by a lot of people, and it's considered a good heart med, but it rinses B vitamins out of the body. chemo, erythropoietin, all dialysis patients, and as they get closer to end stage kidney disease, they have this levodopa and dilantin. It's really a lot of drugs. Aspirin. If someone's on aspirin every day, that rinses B6 out of the body. If someone has chronic urinary tract infections and they take, some antibiotics daily to try not to get those infections, then you give these people hormones and their hormones aren't going to work because they're rinsing out B vitamins. And then I thought, God, let's take a look at all the Bs, because all the Bs are interrelated, like the hormones are all interrelated. So this is the whole list of all the meds that lower B vitamins. So I just that spun me off on trying to do a good job of answering you, that you got to take a look at the drugs that rinse out nutrients. And if people are on those drugs, maybe the reason they're not responding to whatever you're telling that patient to do is because as soon as they can take something in, they rinse it out. I think that guy was on I don't remember, Carol, wasn't he on an acid blocker? His last drug was an acid blocker,
Yeah,
right?
well, he was on Protonics.
Right. So if he's on an acid blocker, his hormones aren't going to work.
Mm-hmm.
You got to, see if you can find out why he's on them, how long he's been on them, see if you can get at the cause of that. Because if he's on an acid blocker, you might not be able to get him really well because he's not absorbing a lot of stuff. Right?
Yes, thank you.
So, okay, so here's one. Lisa's 41 with a primary pituitary adenoma. So that's a benign growth, but it can get large enough to make pressure and make disability. Treated with bromocriptine. So what acts like a nutritional bromocriptine that will not elevate prolactin? Pyridoxal 5-phosphate. Oh, I put pyridoxal 4-phosphate. I don't know why I did that.
Your humanness is showing through.
That's funny. It could have been pyridoxal 11-phosphate, but no, I put 4. Okay, this is pretty funny. I'm getting entertained now. I usually am entertaining you, but I'm letting myself get entertained at the same time that we're moving through this together. Okay, so recent MRI shows decrease in the size of adenoma. So it's whatever you're doing, treated with bromocriptine. Well, it continues to struggle with her weight. She's nearly 300 pounds. Well, first of all, I would give her pyridoxal 5-phosphate with a backup B complex. And you don't want to go above 100 milligrams, because above 100 milligrams of P5P, not P11 or P4P, but P5P is associated with possibly getting neuropathies, which the minute you go off the B6, this is the phosphorylated active form of the B6. So it's pyridoxine hydrochloride goes to pyridoxal 5-phosphate. So that's the deal. It's the active form of B6. It costs more money for a vitamin company to put it in there. It's much more expensive. It might cost several $100s of what kilo or something, where the other thing costs a few cents a kilo, when you're looking at putting this in a product. But this is the form that's pre-digested, because not everybody can absorb pyridoxine hydrochloride. So some people are taking B6, but they're taking a form they can't absorb. So this is the form that everybody, on the whole, but never say never in medicine, can absorb. Low ferritin, so stomach acid challenge, zinc low on. So what was the result of her stomach acid challenge?
Oh dear.
Okay, no worries.
Yeah, I don't recall.
Because she had, well, anyway, pyridoxal 5-phosphate helps lower prolactin, and it also, it's been linked in the treatment to act like bromocriptine without the adverse issues. Okay. So I would consider P5P 50 milligrams twice a day with a backup B complex. Hair loss, I would look at the stomach acid. But hair loss is really, really tough. Many, many women, as they start to get older, start to get hair loss these days. And there's so many multiple reasons for hair loss. The first one is the thyroid. The second one is iron insufficiency, because iron brings oxygen everywhere, and the hair follicles are growing so quickly they have a very high oxygen demand. So you got to get that iron fixed, or put them on nitric oxide boosters, because low low hair loss is also kind of a sign of cardiovascular stress, because your circulation isn't ideal. If you had great circulation everywhere, you probably wouldn't have hair loss, unless it's, of course, there's hormonal reasons, and there's like thyroid, and there can be in some men a genetic inheritance to be bald. Not everyone's bald because something's wrong. Um, and there's stress. You can have hair loss years after the really severe stressful event. So it's very hard to tie the events together. And at the same time, um, you might not even have thought that event was as stressful as it was on your physiology. You don't know how long your cortisol stayed elevated and how things happened. But hair loss can really happen with stress. So there's so much more cultural and planetary stress and COVID stress and hypochondriacal society that nobody feels well. And everyone yelling at each other. It's countries coming together saying the planet is being threatened by global warming, and the whole planet is, I mean, this is a very stressful time, when you would think it makes sense that a lot of people are experiencing idiopathic alopecia, but it is related to planetary stress. I think it's very real. And I don't think it's a minimal thing, but nonetheless, people come to you for answers, and they don't want to hear that. So I would start with the P5P, the backup Bs, the getting that iron, getting the ferritin level. I don't know. I always want to know what the iron level is. And the other thing I ask a lot in my intakes, Carol, is if they have a history of sinus issues, infections, congestion, because your gut starts in your nose. And I am finding a lot of people that have extreme dysbiosis in their nares, sinuses. So I was using beg spray, and that didn't work. So now I've been going to people nebulizing, and it's hit or miss, but there's a lot of people with tremendous amount of mold and bacterial infections and biofilm, and that's all dripping down into their gut. So gosh, we're so much sicker on so many different biomes even. Is that helpful with this patient?
Yes, thank you.
Okay, so where are we? Okay, we're at 1 hour. So I'm almost done. I think here's, this is a patient who had a history of meningioma, but it had progesterone and estrogen receptors on it. So how do you move forward? Do I treat the same as history of ER positive breast cancer? And she wanted to do just estrogen, but I will not I already answered that a little bit early on.
Yes, you did. Yes, you did.
I think there's a case to be made for, first of all, I put them on hormone balance and protect for sure, because that helps cause controlled growth, and you want controlled growth at this meningioma. And I would probably feel better. I do high dose melatonin and testosterone. I'd start again with iodine, testosterone, looking at the parietal cell efficiency. I would feel fine with giving testosterone, because it tends to be anti-proliferative to tumors that have estrogen receptors on them. It's, it modulates with estrogen. So the other hormone I would ponder would be 2-methoxyestradiol in this patient. And I would look it up. I don't know. I think there might be one paper. I don't know whether it's an in vitro or a human study with 2-MeO and meningioma, but I would look into that.
I can't find a compounding pharmacy in Minnesota to make 2-MeO.
Well, now Jerry might ship you some. I don't know. They might talk, if they're really interested, they could talk to Jim Hinseer. That's where I get it in Texas. and then Creative Scripts and Uptown Pharmacy in Naples now carry it for my patients. I was just when I had the worst laryngitis. What happened was I got terrible laryngitis 2 weeks ago on Tuesday, and I still had 2 full 8-hour days of patients. So I stayed in the apartment and saw them in telemedicine, but I completely strained my voice. I should not have been talking, but I had wall-to-wall patients, and I'm only there 1 week a month, and I I didn't realize I was straining my vocal cords that much, and it meant that I had no voice then for weeks because I strained my vocal cords so bad. But I bumped into this woman. This is about 2 MEO. Sorry, it's long-winded. I don't mean to be so long-winded. Sorry. Um, and she had 3 different cancers, and she was in Canada. It was a telemedicine visit, of course. And I had lectured in Canada right before the pandemic, and I'd met this phenomenal compounder, and I reached out to him, and he said, I know somebody right in her town, because she was way out there in Canada, and she'd been schlepping to the United States and doing all these things, and she just kept getting cancer back. So she'd been to Mexico and this and that. So it just so happened that last weekend there was a compounding pharmacy convention in Houston, Texas, of all things. And this guy in her hometown was coming here for this convention of all things. And my guy that I get my 2-MEO from was close by his pharmacy. I would definitely do melatonin, and I would definitely do iodine. Because remember, iodine eradicates breast cancer cells, but it's never been, we don't know if it eradicates meningioma cells, but most likely probably if there were money in it to test it. Most of the iodine cancer research, most of the authors said in the conclusion, this should be used as adjunctive in breast cancer care patients or hormonally driven cancer patients, and to not do so makes no sense with the literature. But it's a mineral, it's a metal. No one's going to do anything about it. There's no money in it. So it's not been tested on meningioma, but it probably would be a really good thing to consider with this patient. I would start with testosterone, then consider 2-MEO, then down the road, progesterone while on hormone balance and protect and receptor detox. And I would consider iodine. And I wanted to get into this, and then we'll call it a day. Is Lisa on? Lisa, are you here?
I think she was going to be out and was going to watch the replay.
Oh, okay. Okay, so this is a great question. She said she did a 2-week course with A4M, which means that I think this was taught a lot by Pam Smith and Sahar, who owns a compounding pharmacy in Ann Arbor, Michigan. And several of the instructors, what they're now teaching at A4M, is that you need a 5-day break from estrogen each month to give the receptors a break. So I reached out to the doctors that discovered the receptors, and I said, do you think that this makes sense or this doesn't make sense? And they said, well, if you were trying to mimic Mother Nature, it would make sense, but it doesn't make sense when you get older and you're using hormones to prevent aging and other things. You're not trying to induce a menstrual cycle with exactly the same variations in the menstrual cycle. So let's take a look at the science and see what the answer would be, and what my answer is, what David Brownstein's answer is, and what David Rosensweet's answer is, because I called and reached out to everybody and asked them if they would talk to you as though they were talk to me the way I would say you would answer this question. So you're going to get that in a few minutes. First of all, this is the cycling range that just comes up in the literature. This was a study that came out of, this was from the Human Reproduction and the IV of Fertility Research, and it's the impact they were looking at what low progesterone does to get fertility, and they said it should be at least 8.8 nanograms per mil. And we know from the breast cancer, there's all the studies where women who have higher levels of progesterone, when they go in for breast surgery for breast cancer, live longer, have less recurrence, have less death if they do have recurrence. And this has been proven in maybe 50, 60 articles. It is a huge, to not give progesterone before a breast surgery is almost malpractice. If you follow the science, you would follow that science, but nobody's following that science. So I just threw this in with that. And in Safe Hormones, Smart Women, I talk about a hormone holiday. So I have a chapter where I talk about giving the research and giving women with breast cancer hormone replacement. And when they track women who are cycled when they're younger, especially the first 2 years after breast cancer treatment, if they're cycled, so they get progesterone in the middle of the month, or they, if they're younger, or they get at least progesterone 3 weeks out of the month, but more doubled in the middle of the month if they were older, they had less recurrence when compared to women who only had hormones all throughout the month with any hormone holiday. That's how I started first writing about hormone holidays and Safe Hormone Smart Women. I think this is where the concept kind of came from, was from reading those breast cancer researchers, but it's become more nuanced over time. So she said, for cycling women in the early perimause, this is Lisa, early menopause, I usually give progesterone from days 12 to 28. If later in perimenopause and they start experiencing hot flashes and in other issues, I add estrogen patch to change every week, when normally you give an estrogen patch twice a week. So she's giving a lower dose of an estrogen patch. And if the woman is having issues in postmenopause, I use continuous estrogen patch and oral, and I don't cycle at all. But now I'm confused because A4M says all women should cycle for 5 days, and 5 days seems like a lot to take a look at. So, is there any validity to needing a break from hormones 5 days out of the month? It seems like a hassle, especially if each patch lasts 3.5 days or 7 days. If someone is on a patch, would you cycle progesterone, or what would you do? This is really crazy. So, if someone is perimenopausal, and closer to the beginning, because perimenopause can be a few years, a year, it could be 10 years. You want to kind of know how much they've been having erratic menstruation and heavy flows and spotting, and things aren't like they used to be. So anxiety, because progesterone is an anti-anxiety hormone, so they might have more anxiety. That's one of the symptoms too. You can continue to cycle because they're still closer to when they were premenopausal. And if they had a history of breast cancer the first year or two out, depending a little bit on their age, but I would also cycle, not necessarily take a hormone holiday, but with progesterone. In the studies, they were looking at progesterone cycling with breast cancer protection. So you have several options. You can give more progesterone in the luteal phase. It could be, I usually do day 15 to day 25, or and then none the rest of the month. Or if they do better, they don't do well off of it, you can just give it for 3 weeks. In the middle of that time, just double it. So you can give, let's say if you're giving 50 milligrams anytime outside, day 15 to 25, and then 100 milligrams from day 15 to 25. You can cycle it if you want. But once you get menopausal and you don't have any hot flashes and you're doing better and better, the need to cycle it is less and less, because you don't really need to totally mimic a premenopausal pattern. This was the thinking by Dr. Henry Lemon and Dr. Jonathan Wright. The more you mimic nature, the less trouble you get in. But we don't know if that's really true all the time. They didn't do that in the Women's Health Initiative, and they still got all those really positive responses. So let's take a look at what a variety of different doctors do and then summarize it all up together. The thought is, if a woman's pretty low, going on estrogen fumes, so she goes off estrogen for a day and she gets hot flashes, she's hardly on enough. She's either underdosing, or she's somebody that shouldn't be taking a hormone holiday. She's too low on the totem pole of estrogen. She goes off it for a day, she gets symptoms. Someone else might go off it for 3 days and not get any symptoms at all, and kind of feel a little less bloated and a little bit more energetic. That person actually might have been overdosed. So different people can respond differently to hormone holidays. Why do we think a hormone holiday would be different than anything else in functional medicine, where it needs to be individualized, right? It needs to be individualized. So Dr. Brownstein says he only cycles a little bit of perimenopausal women, and when they become postmenopausal women, like pretty much the second year of menopause, he doesn't cycle them at all. He just gives them the hormones throughout the whole month. But you might, if they had breast cancer, the first 2 years of breast cancer, because there's some studies that suggest this, might cycle the progesterone a bit. And if you want to give it the whole month, you might just double it on the middle of the month if they don't do well going off of it for a bit. You don't have to just do a 5-day hormone holiday. And I thought the way that David Rosensweet answered your question, Lisa, was really great. So I said, do you do hormone cycling and hormone holidays? He said, yes and no. And it is dependent on their estrogen levels when determined. And he uses, there's two 24-hour hormone labs. There's Meridian Valley Laboratory and there's Rhine 24-hour urine. For starters, if they are at the low end of total potent estrogens, which he says with 24-hour urine is 8 micrograms per 24 hours, we are inclined not to stop. So if you feel a woman is kind of low in estrogen, and what are the main estrogen? If she's losing words, her memory seems to be going, she's having hot flashes at night, she's having bone loss, those kind of things, um, she might not be a good person to be going on a hormone holiday, even if she's early on, even if she's in perimenopause. Um, if they are the more robust end, and he says that goes closer to 14 micrograms per 24 hours, we do stop. And he says they tell women to just take a break the first day of the month, a 1-day holiday. He said it's all about what happens when they stop. If they feel worse when they stop, they don't do the 1-day holiday. If they don't feel worse when they stop, they don't have to feel better. If they just don't feel worse, then they might give them a 1-day holiday. He says we suggest stopping hormone replacement on the first day of the month. If they get a hot flash, for example, that day or that night, we say don't do this monthly hormone holiday. They're running on the lean end and do not need to create a hot flash, as that's stressful. So prior to testing them, if we see that they are using robust milligrams of bias, might be, remember the typical dose is like 0.6 to 0.8 to 2.4 to 2.6 milligrams of estrogen. I take, because I have so little organs, almost 3 milligrams of estrogen a day. So different people have different, so if we're at the high end of a robust amount of milligrams of biased, we can do a clinical trial, stop for 1 or 2 or 3 days and see what happens. If they develop a hot flash on day 1, there's an absorption issue, and we say you are not a woman who's a candidate for a hormone holiday. If they go, for example, 3 days and then develop an insufficiency symptom, we have them stop for 2 days a month. So they have them stop from 1 to 2. It's all for me. If a woman is perimenopausal, I'm going to do some kind of cycling with the progesterone. And it makes sense with the estrogen because you're mimicking a premenopausal body estrogen goes up twice and it goes down to almost nothing twice. So it has some time in the cycle where the receptors do naturally get a break. And then with breast cancer patients, progesterone cycling has been shown to give them better odds, at least the first few years. And then once they become menopausal, after that first year, you can start cycling them, just give the same amount of hormones all month. They don't need to take a break at all unless you feel there's some extenuating circumstances. It sounds like David Rosensweet does continue to have women to take a break. After a woman has been postmenopausal, I just have them go and take the hormone, the same dose all through out the month. And Dr. Brownstein says he does the same thing. So there's variations on opinions of this. Why you would need 5 days off sounds like your your receptors would become forgetful. They want to be activated. They want to be used. They go acquiescent in older age, and you wake them up when you give them back to somebody who's older. So you want receptors that are awoke. Is that the new terminology? I don't even really understand. People keep trying to explain to me what that is, and I still can't wrap my brain around it because it sounds so harsh that I can't get over that sound of it. Anyway, So cycling is not set in stone. There's no set person who knows about it. The idea that it should only be 5 days for all women seems pretty cookie cutter to me, that we try and get away from in functional medicine. And there's times to use it and times not to use it. And you can choose to use it or maybe use it less. But part of the way you want to determine it is how a woman responds by going off of it a day or two or three. I don't really if they're perimenopausal, I cycle them. If they're early on in breast cancer, I cycle them. The first year of menopause, I cycle, and after that, I don't cycle at all anymore. So most of my patients are really older, but not all. But I don't know if that's a guideline, but hardly anyone knows any of this stuff. Women go out, and they're all asking so many practitioners and doctors questions, and people don't have this information to answer it. I so appreciate that you guys are here. And I know you can only do so much. I don't know how to, next year I want to figure out some certification programs and really focus on much more hormone training, because we need to know this stuff, don't you think? And we have to educate our women who are pregnant, because kids are just so ill. Kids are so ill. Are you seeing more and more ill children? Anyway, okay, so were there any other questions that I didn't see? I don't think so. And we're going to pin down, Leo's in the midst of moving. And when he's all situated, he said, which he wouldn't let me pin him down soon, but as soon as he's situated, we're going to be like the first group he talks to. And he'll give us his long COVID, and we can dive into all those COVID things then. And you should get your questions ready. But if you like this and you thought this was helpful, please be inspired to send case reports in like Lisa and Carolyn did. Carol did. I always call you Carolyn. Is that okay? I'm sorry.
That's okay. That's okay.
My aunt is Carolyn, so I don't know why I've got my aunt's name on my brain. Sorry about that. So we should be doing this a lot more, don't you think?
Mm-hmm.
But I need your questions. Hey
Well,
there,
I
Christine
have almost
Roche.
5,000. I have almost 5,000 patients, and so I can keep on. I can keep on bringing case studies to you.
Well, I'd love you to. I just don't want you to
Okay.
feel like you have homework. Hey,
Oh,
Chris, you
no,
look really pretty in your red jacket. Yep.
this is so incredibly helpful. It doesn't feel like homework at all. I mean, just to be able to. We appreciate you, Lindsay, so much, because you are such a wealth of knowledge, and you always come with all of the studies to support the things that you're saying and lead us in a good direction and give us such valuable information. We all really appreciate it.
Oh, thanks. It means a lot to me that you say that and you feel that way. I just want to get this out more. What's really sad is within the hormone world, there's so many people saying the way other people do everything, it's wrong.
Mhm.
And I worry that this disparaging of each other is going to do us in.
Yeah. Every single patient I see that I have on hormones, I have a conversation with how they will be approached likely by their standard care providers, because they need to know how to respond to those providers when they're like, well, you're 75, what are you still doing on these hormones? And every once in a while somebody slips by me and I haven't talked to them, and they come back and they're like, my doctor says I should not be on this is so dangerous for me, and on and on and on and
I
on.
know you hear this in so many things.
Yeah.
You know, what was I? Oh my God, this is such a big deal. Oh, yeah. So the 7 million study that was published in preprint reviews. The Yale and the British Medical Journal have that preprint journal, and they publish things that have not gone through peer review yet. And it came out in May 2022, and it basically said, women live 20% longer. They have statistically less of 5 cancers. They do better on estrogen. And if they're on natural steroids and natural progesterone, they do even better. But Premarin, they did well too. It's just they did best. And they went through delivery modes, they went through everything, and that is sitting there. It is being blocked. Nobody is moving it forward into peer review. If you put the name of that in, other studies you can often read pre-print and pre-whatever in peer review. There's no mention of this anywhere. And I'm and it's from our NIH and our National Library of Medicine, and it's a sin. It's just a sin. It's crazy. Anyway, well, I hope you like my rantings and so forth, and I'm glad that they're helpful. But your questions were really helpful to me, and Christine, we'll keep your questions in mind, and we'll keep them for Dr. Galland and whoever else asked a great COVID question. It's not that we're not going to answer them. It's just this isn't the venue, and I'm not the expert for that. So, okay.
Thank you, Lindsay.
Great hanging with you guys. Blessings, everybody.
Yes, thank you.
Bye bye.